Start in 5 seconds.
Okay.
Please start.
Good evening, respected doctors from all across the country. I am Saurabh Agrawal. On behalf of Lupin Limited, I welcome all of you for AHA 2020 at glance. It's a pleasure to have your presence for this AHA update, which recently got concluded in a virtual format. We have a pleasure of having eminent Indian as well as international faculties with us. And I'm sure next 2.5 hours of this symposium would be definitely knowledge enriching for everyone. We are looking forward for active participation from all of you. And I believe in this troubled time of COVID-19, all of you, along with your families and loved ones, are doing well. With that best wishes, I would like to start the session by inviting our President, India Region Formulations, Mr. Rajiv Sibal. Mr. Sibal is heading the operations for Lupin India and Nepal, Sri Lanka, Bangladesh, and would like him to please give the keynote address and set the ball rolling for today's AHA at Glance 2020. Over to you, sir.
Thank you, Saurabh. Am I audible?
Yes, sir.
Good evening, respected doctors. I hope you and your loved ones are safe and taking necessary precautions to fight COVID-19. Today, the world is experiencing an unprecedented crisis, and we at Lupin salute your selfless effort and commitment in fighting this pandemic and protecting the society. Despite the nation experiencing lockdown, every Lupinite has ensured consistent continuity shoulder to shoulder with COVID-19 warriors who are fighting against all the odds. Lupin continues to extend all the support to you and the entire medical fraternity in the fight against COVID-19. Lupin has been at the forefront of fostering scientific outlook and advancing academic awareness. So today, we are proud to have with us global experts in the field of medicines who would be sharing highlights from AHA, latest breakthrough evidence and late-breaking science in the fields of heart failure, preventive cardiology, statins, acute coronary syndrome, and hypertension with you all. I'm sure next 2.5 hours, as Saurabh said, would be an enriching and enlightening session for all of us. It's my pleasure to be a part of this forum, which is graced by the presence of distinguished international faculties, Dr. John McMurray and Dr. Peter Thought, along with country's leading QLs, Dr. A.B. Mehta and Dr. Praveen Chandra. Lupin's pursuit for excellence in the field of medicine has helped it transform into a transnational pharmaceutical organization with global footprints in the US, Europe, Asia, in addition to India. Lupin is one of the trusted and preferred industry partners by the medical fraternity, professional bodies, and also by peer organizations, making us the organization with largest number of in-licensing partnership in India. Lupin has consistently maintained leadership position in cardiodiabetes space and shall continue to contribute to the well-being of the patient by producing high-quality novel drugs. I would like to conclude by thanking you all as you continue to treat patients during these testing times, and please be safe and take care of your family. Thank you. And I now hand over this to Saurabh to formally get into this particular program, AHA. Over to you, Saurabh.
Thank you, Mr. Sibal. Thanks a lot for setting the context about today's program. And respected doctors, as I said, we believe next 2.5 hours will be academic feast, and we look forward for your academic participation and feedback and suggestions here. I have a pleasure of introducing our eminent Indian panelist and chairperson, and I would request, so first and foremost, I would like to introduce the godfather of cardiology in India, Dr. A.B. Mehta. He is a distinguished cardiologist with a renowned teacher in him, and has been in the field of cardiology for multiple decades. A Padma Shri awardee from Government of India in 2004, has been awarded as Maharashtra Gaurav Award for most outstanding contribution in the field of cardiology by Government of Maharashtra. He is also being distinguished as CTO Man of the Year Award for 2008, first of its kind for India chapter, prestigious Dronacharya of Intervention Cardiology Award by CME Award of Union Ministry in 2019, and Lifetime Achievement Award by the leading Cardiovascular or Cardiology Society of India conference in 2018. He has also been awarded with Golden Contribution at AICT in 2012 at New Delhi, and has got Andreas Tutek's Award, Memorial Award for dedication and growth of angioplasty in India. Words are enough to describe the legacy of Dr. Mehta and the contribution that he has made in the field of cardiology. A beloved teacher, a great cardiologist, and we have immense pleasure to have your presence, sir. So thank you very much, Dr. Mehta, for your presence today. I would like to introduce another leading eminent chairperson with us, Dr. Praveen Chandra. Dr. Praveen Chandra is a leading cardiologist from Medanta Hospital in Gurgaon in the NCR. Dr. Praveen Chandra, again, a Padma Shri awardee from Government of India in 2016. He has done immense contribution in the field of cardiology. He is currently the chairman of intervention cardiology, like I said, at Medanta Medicity, Gurgaon. He is recognized as a leader in angioplasty in the country. He is proficient in a lot of new devices and technologies which are used in invasive and intervention cardiology. Served as a director of cardiac cath lab and acute MI setting at Max Hospitals and Escorts Heart Institute and Research Center. First time in India, he did percutaneous aortic wall replacement without surgery, and he has also been first in percutaneous mitral valve repair. I think many such first initiatives have been taken by Dr. Praveen Chandra, and we have a pleasure of having his presence in today's meeting to guide us through. With that brief introduction of our two leading chairperson panelists for the evening, I would like to formally hand over to Dr. Ashwin Mehta to please guide us through today's session, and please set the ball rolling for the academic feast. Over to you, sir.
First of all, thank you, Saurabh, for a very generous introduction. More than its real value, I think it is tinged with a lot of love and affection, which I really appreciate. And I also compliment you and your team, Rajiv Sibbal and you people, to have such a beautiful meeting so that sitting at home, we are able to have an AHA highlights and glance without any discomfort, with all comforts of our own room, our library, and that I think is great. We have now learned through this COVID-19, which has imposed a lot of restrictions in our traveling and getting together. We have learned new methods that how with the virtual imaging, and we learned the subject. It's a different way of learning, but I think it is turning out to be very effective and interesting. It's very, although it is far less expensive. Now, none of us could go to United States to attend AHA in person, and the meeting did not take place in person. So the highlights, which we all might be busy in one way or other, and if somebody is making a ready dinner for us, and then therefore we can enjoy this, and I think that's a great opportunity. And I'm very, like you, Saurabh, I am also equally keen to listen to Dr. Peter Tu and Dr. John McMurray so that he updates us from what's happening in the cardiology field. Thank you, Saurabh.
Thank you, sir. So we'll request sir to start with our first session with Dr. John McMurray's introduction and start. So can we go ahead with the session now?
Okay, I'll just introduce Dr. McMurray before he starts.
Sure, sir.
And before this, I must thank Lupin for this very nice organization and inviting very nice speakers today. And it gives me pleasure to introduce Dr. McMurray, who is Professor of Medical Cardiology from University of Glasgow. And he is, he has been working as an honorary consultant cardiologist at Queen Elizabeth University Hospital and has been honored by the ESC for his outstanding contributions in cardiology. So Dr. McMurray is going to talk to us from the AHA, the highlights from AHA. And of course, it will be very interesting to hear from him and of course have some discussion later on. So Dr. McNamara, please.
Okay, thank you very much. I'll just share my screen and put that into full screen mode. So thank you very much for the introduction. Thank you very much for inviting me to talk about what I think were the highlights from the American Heart Association scientific sessions related to heart failure. And I'm also going to talk a little bit about chronic kidney disease, areas that I'm particularly interested in. And I have to say, this was one of the most interesting American Heart Association scientific sessions for many years, as I hope I'll be able to tell you in the next few minutes. So here are my disclosures. I do clinical trials and my university's paid for my participation in these. So I'm going to start with, I suppose, what has been the story of the past 5 years more generally, and that's the story of the SGLT2 inhibitors, these drugs that were originally introduced as glucose-lowering therapy for type 2 diabetes, but we now know have an extremely important role to play as treatments for heart failure, irrespective of diabetes, and also a very important treatment for patients with chronic kidney disease, again, irrespective of whether or not they have type 2 diabetes. And at the American Heart Association Congress, we saw some new data that reinforces the value of these drugs in both of those conditions. Just to remind you of the background, in the past year approximately, we've seen 2 large trials, firstly DAPA-HF, and then more recently this year, EMPEROR-Reduced, 2 trials in patients with heart failure and reduced ejection fraction. These were ambulatory patients in the community, chronic heart failure, ejection fraction of 40% or less. Importantly, in both of these trials, patients were included with and without type 2 diabetes. And as you can see, in both of these trials, SGLT2 inhibitor therapy reduced the risk of the primary endpoint, which in both trials was essentially time to first occurrence of worsening heart failure or cardiovascular death. At the American Heart Association Congress, there were new data presented from the most recent of those 2 trials, the EMPEROR-Reduced trial, looking at the other important goal of therapy in patients with heart failure. So yes, reducing death is obviously important, reducing hospital admission is important, but it's also important to improve symptoms, to improve quality of life, or at least to maintain quality of life. And Javid Butler from the EMPEROR-Reduced investigator group reported their findings in relation to quality of life with empagliflozin in patients with heart failure and reduced ejection fraction using the Kansas City Cardiomyopathy Questionnaire. This is a 23-item questionnaire that asks about various domains of a patient's well-being. There are a number of different scores, and I will show you those in the next slide. So here you see the clinical summary score, which looks at symptoms and physical limitations. The total symptom score, which just looks at the questions related to symptoms, and the overall summary score, which looks at symptoms, physical limitations, social limitations, and quality of life. And what these figures show you is the proportion of patients having a clinically meaningful change, which is a 5 or greater point change at different time points. So if you look at this panel, you can see at 3 months after randomization, the likelihood that patients would have a 5 or greater point improvement in these scores or a 10 or greater point improvement in these scores. So 10 is a very large improvement, and you can see that whichever change you look at, whichever score you look at 3 months and at later time points at 8 months and 12 months, you can see that significantly more patients improved with empagliflozin compared to placebo. If you look at deterioration, then significantly fewer patients had a deterioration in symptoms. So what this trial is telling us is that not only do these drugs reduce death, reduce hospital admission, but they also improve symptoms and quality of life. They do that very quickly. These changes are demonstrable and significant. Within just 3 months of starting therapy, people improve, and they're also less likely to deteriorate, more likely to get better, less likely to deteriorate. So collectively, these two trials in ambulatory patients with chronic heart failure clearly demonstrate the important value of this new type of treatment for HFrEF. But there are remaining questions. What about HFpEF? We don't know about these drugs in that other major heart failure phenotype. What about patients who are hospitalized? Can you start this treatment safely in patients admitted to hospital? Is it effective in patients who've been admitted to hospital with decompensated heart failure? And then one of the key questions about these drugs is, how do they work? We've really had virtually no mechanistic data about what these drugs are actually doing in patients with heart failure. But as I'll show you in the next few slides, the American Heart Association Congress was really incredible for the new information that it provided in relation to these outstanding questions, these gaps in evidence. And that is firstly because of a trial called SOLOIST, worsening heart failure. So this is a trial with a drug called sotagliflozin. This is a drug that also blocks SGLT1 in addition to SGLT2, but we think fundamentally this is the same sort of treatment. And the SOLOIST worsening heart failure trial was very different than DAPA-HF, very different than EMPEROR-reduced, because the SOLOIST trial included patients who had been admitted to hospital with worsening heart failure. Patients did not have to have heart failure with reduced ejection fraction. This trial enrolled patients with reduced ejection fraction, but also patients with preserved ejection fraction. It was a study that only included patients with type 2 diabetes, and it was originally intended to be a very large study, but because of issues in relation to funding, there's a change in sponsor, and because of COVID-19, this trial was actually stopped early after recruiting just 1,200 patients instead of the originally anticipated 4,000 patients. But as you will see, that didn't really matter, because here is the primary endpoint. So the primary endpoint in this trial looked at total events. So it looked at cardiovascular death and worsening heart failure events, and didn't just look at first events. It looked at first and recurrent hospital admissions, as well as urgent treatment for heart failure given in a non-hospitalized setting. So, for example, patients who went to the emergency department and required intravenous therapy for worsening symptoms. So you can see here the cumulative incidence curves for the placebo group in the SGLT1/2 inhibitor group. There was a 33% relative risk reduction, a very large risk reduction, a very small number needed to treat over a remarkably short period of time. The median follow-up was only 9 months. And in fact, this treatment benefit was discernible within just 28 days of randomization. There was a statistically significant benefit, which is what we've also seen in the DAPA-HF trial. So evidence that you can use these drugs safely and effectively in patients who've been hospitalized with heart failure, and in those patients who've been hospitalized with worsening heart failure, the benefit of treatment is apparent very quickly after starting therapy. And then if you look through all the other endpoints, this was a relatively small trial, had relatively few deaths, so there was no significant reduction in cardiovascular death, although the hazard ratio was favorable. But as you can see here, heart failure, hospitalization, and other events were reduced significantly. And what was of particular interest was the subgroups in this trial, because if you remember, I told you this trial included patients with HFrEF, but also patients with heart failure and preserved ejection fraction. And if you look here at the patients who had an ejection fraction of 50% or above at baseline, there was a significant benefit of SGLT1/2 inhibition compared to placebo. And if you look at patients who were started on treatment before discharge as opposed to after discharge, again, a completely consistent benefit. So this study gives us the first evidence that these drugs might be doing something good in HFpEF, as well as HFrEF. So it's also important, obviously, to understand tolerability and safety in these patients who've been acutely decompensated. And overall, as you can see, the safety profile was pretty good, except for two adverse events that were a bit more common in the SGLT1/2 inhibitor group. Diarrhea was more common, and severe hypoglycemia was more common. Now, severe hypoglycemia was rare, but there were more events in the sotagliflozin group than the placebo group. The diarrhea group here is interesting. This is not an adverse event you see with empagliflozin or dapagliflozin. You do not see this with SGLT2 inhibitors. This is a side effect of inhibiting SGLT1, which is found in the gastrointestinal tract. So this is a side effect that we haven't seen in the previous trials, but it's interesting to note that difference. So the other question that we got some answers to from the American Heart Association was this question, which has really been puzzling all of us. How do these drugs work? What are they doing in patients with heart failure? How are they bringing about these incredible benefits? Because after all we knew about them was that they increase urinary glucose excretion. That can't possibly explain why they're beneficial in heart failure. So there were two smaller mechanistic studies presented at the AHA, both looking at left ventricular remodeling, one from New York City and one from our group in Glasgow. So here is the study from Glasgow. So this is a cardiac MRI left ventricular remodeling study. So we randomized 105 patients with heart failure and reduced ejection fraction. They had either type 2 diabetes or pre-diabetes, and they were treated for 9 months. So everybody randomized was followed for 9 months. Our primary endpoint was change in left ventricular end systolic volume index. So we were hoping to show that empagliflozin would decrease left ventricular end systolic volume. So here you see change from baseline to 9 months. And you can see that the empagliflozin group shown in red had a significantly greater reduction in left ventricular end systolic volume, and indeed in left ventricular end diastolic volume, than the placebo group. So adding empagliflozin on top of conventional therapy for HFrEF resulted in favorable left ventricular remodeling in our study. And in the New York trial, there were even more striking benefits. So this was also a cardiac MRI randomized trial, slightly smaller than our study, 84 patients. This was in a study of HFrEF patients who did not have type 2 diabetes at baseline. There was a 6-month follow-up period rather than 9-month follow-up period. And here you see changes in left ventricular end diastolic volume, systolic volume, ejection fraction. In this figure, the empagliflozin groups are shown in blue and the placebo group shown in red. And you can see, for example, there was a significant improvement in left ventricular ejection fraction with empagliflozin compared to placebo, as well as what we found in our study, which was a reduction in end systolic and end diastolic volume. In this trial, there was also an improvement in 6-minute walk distance and peak oxygen consumption during exercise tests on treadmill, as well as an improvement in health-related quality of life measured using the Kansas City Cardiomyopathy Questionnaire. And in both of our trials, there is a reduction in NT-proBNP. So for the first time, some mechanistic data about these drugs having a favorable effect on the heart, consistent with their clinical benefits. So we will be getting more studies with these drugs. There are 2 trials in HFpEF still underway, Emperor Preserved, which we'll hear about next year, Deliver, which we'll probably also hear about next year, and another acute heart failure trial, which is currently recruiting. But there is no question that the new guidelines are going to give SGLT2 inhibitors a class 1 level A recommendation, because we now have such strong data from multiple trials that these drugs improve morbidity and, importantly, mortality. And you've probably seen figures like this. This is what we're all showing. These are the 5 different pharmacological approaches we now know improve survival in patients with heart failure and reduced ejection fraction. 5 different mechanistic physiological pathways interrupted by these pharmacological interventions, although of course given in 4 pills, because sacubitril/valsartan is given as a single tablet. But these are the pillars of pharmacological therapy for heart failure with reduced ejection fraction in 2020, going forward into 2021. So now I want to change gears completely and talk about another remarkable trial that was presented at the American Heart Association scientific sessions. And this is about the use of intravenous iron to treat iron deficiency in patients with heart failure and reduced ejection fraction. As I'm sure many of you know, we've had really quite strong evidence now for a few years that iron deficiency, and I don't mean anemia caused by iron deficiency. I'm talking about iron deficiency itself. The patient may not be anemic. Iron deficiency is very common in patients with heart failure. It probably affects about 1/3 of ambulatory patients, maybe half of hospitalized patients. We know from 3 reasonably large randomized trials that intravenous iron therapy improves symptoms, quality of life, and exercise capacity. But it has to be intravenous iron therapy. Oral iron therapy does not work. But what we don't know is whether intravenous iron therapy reduces hospital admission or death. And that's the evidence that we've been waiting for. So we had been waiting for a number of trials, the first of which to report was the AFFIRM acute heart failure trial. This was, as the name suggests, a study of intravenous iron therapy carried out in hospitalized patients, so patients admitted to hospital with decompensated heart failure. Again, it was a modest size study, so it was about 1,100 patients. Although the primary endpoint was cardiovascular death and heart failure hospitalization, realistically, this study was only powered to look at reduction in heart failure hospitalization. Like the trial I've just shown you, it had an interesting design, looking not at our usual endpoint of time to first events, but looking at total events. So as shown in this cartoon here, looking at all of the events that would occur in this patient. Our usual endpoint, the usual way in which we analyze trials, would only take account of this first heart failure hospitalization. But this new approach to looking at outcomes looks at each of the events that occur. So in this patient, there would be 5 events that were accounted for, 4 hospital admissions and cardiovascular death. So here you see the results of the AFFIRM-AHF trial. If you look at the primary endpoint, you can see that there was a borderline statistically significant benefit, not quite significant. If you look down the list of secondary endpoints, you can see that there was a significant reduction in heart failure hospitalizations. In fact, if the investigators had used a conventional analysis looking at time to first occurrence of either heart failure hospitalization or cardiovascular death, the result of the trial would have been statistically significant. They were affected in this trial by COVID-19, and in fact they had pre-specified that they would do an analysis censoring follow-up of patients in each participating country when COVID-19 impacted that country, led to lockdown, led to reduction in follow-up and hospital admissions. And in fact, in this COVID-19 censoring sensitivity analysis, again, the primary endpoint was statistically significant. So I think this was a positive trial. I think it clearly tells us that intravenous iron therapy reduces the risk of heart failure hospitalization. Now, there are a few, as with every trial, quibbles about it, but I think it's a pretty robust study, and I think it confirms the value of intravenous iron therapy. There are outstanding questions. The main ones, of course, are does this treatment work in HFrEF, and what effect does it have on mortality? Well, we're going to find out more because there are more trials in the pipeline. There are 2 more with the particular intravenous iron preparation used in AFFIRM-AHF, ferric carboxymaltose. So these 2 trials are underway with that agent. One of them is a pretty large trial, 3,000 patients, out of Duke University in the US. And then we have a UK trial with a different intravenous iron preparation, iron isomaltoside, and this trial is should finish in the not too distant future. This is a trial that includes a mix of hospitalized as well as ambulatory patients. But as yet, there is no big trial that is underway in patients with heart failure and preserved ejection fraction. So I think we will see an update in the guidelines in relation to intravenous iron therapy. I suspect that they will give intravenous iron now a recommendation that also includes reduction in heart failure hospitalization as one of the benefits of intravenous iron therapy in patients with heart failure and reduced ejection fraction. So again, changing gears once more to talk about the other piece of big news at the American Heart Association Congress, but unfortunately, sadly not as exciting news as in the other trials. We saw the results at last of our large study with Omecamtiv mecarbil. This is a drug that improves left ventricular systolic function. It does that by slightly prolonging the duration of systole. We had done a phase 2 mechanistic study where the drug seemed to do good things. It improved contractility, definitely improved systolic performance, reduced natriuretic peptides, even reduced heart rate, all the things that classic inotropes don't do. So we were hopeful that we would see a benefit of this treatment. We published the design paper earlier this year. As I said, it was a big trial, 8,000, nearly 300 patients randomized. 25% of them were hospitalized patients. The primary endpoint was cardiovascular death or heart failure hospitalization, but the trial was big enough to tell us whether or not this drug had an effect on cardiovascular mortality. That's why it was over 8,000 patients. And we presented the results of this trial at the American Heart Association Congress. You can see here that the inclusion criteria were a bit different than some of our previous trials. This drug doesn't lower blood pressure, so we were able to include patients with a really low systolic blood pressure. It doesn't affect renal function, so we were able to go to a much lower eGFR. And because it improves contractility, because it doesn't lower blood pressure, we were happy to give this drug to patients who were in hospital with decompensated heart failure. And we deliberately included a quarter of the overall trial population during admission to hospital with decompensated heart failure. As a result of the differences in inclusion-exclusion criteria, the patients enrolled in GALACTIC-HF were a bit different than in the previous study. And in particular, they had a higher natriuretic peptide level than, for example, in Paradigm or the SGLT2 inhibitor trials. They had a lower eGFR. And because this was a more recent study, there was also a higher proportion of patients taking sacubitril valsartan at baseline. So as I said, we presented and published this trial just a few days ago. And sadly, although the trial was statistically significantly positive, the treatment effect size was actually very small. As you can see here, there was an 8% relative risk reduction. So that was significant. The p-value was 0.025, but a relative risk reduction of 8% is sadly not very impressive. And really disappointingly, when we looked at the two components of the primary endpoint, neither of these individually was statistically significant, certainly not cardiovascular death, although, as you can see here, the overall small benefit was driven by reduction in heart failure hospitalization, although that by itself wasn't statistically significant either. So we were, to be honest, terribly disappointed with the result of this trial. We had very high hopes for this drug, but as you can see, it had a very small benefit, although it was significant. Of course, we were interested in looking at the various subgroups, and the interesting subgroup, the one that stands out, is this one, the left ventricular ejection fraction subgroup. So as you can see here, there was a highly statistically significant interaction, which tells us that ejection fraction modified the treatment of Omecamtiv mecarbil. And as you might expect, so we think this is probably real because it's biologically plausible. As you might expect, Omecamtiv mecarbil seemed to be more beneficial in patients who started with a lower ejection fraction. Those with an ejection fraction at or below the median value of 28% seem to be the ones who got benefit. So we are currently looking into this in more detail. It may be that this drug still has a role, but it may be particularly in people with very reduced left ventricular systolic function. So we're actively looking into these data further. Omecamtiv mecarbil does lead to a very small but significant increase in troponin. So that was a little bit of a concern, but we didn't see any excess of myocardial infarction or any other episodes of myocardial ischemia. So we think this drug has a clean bill of health. And actually, one of the very interesting things is that we saw, believe it or not, a statistically significant reduction in stroke. Now, that might be a chance finding, but it could be that this drug, by increasing left ventricular contraction and left atrial contraction, and we've seen in our earlier mechanistic studies improvement in atrial function, this drug may reduce the risk of cardiac thrombus formation, and in that way might reduce the risk of stroke. So a sort of unexpected finding, possibly the play of chance, but mechanistically we could come up with an explanation for this. So to finish with, I'm just going to mention two more trials I think are of interest, and those are new trials in patients with chronic kidney disease, because many of our patients with cardiovascular disease today have chronic kidney disease. And of course, patients with chronic kidney disease attending nephrology clinics very commonly have cardiovascular problems, and in particular develop heart failure. And in fact, there have been 4 trials with SGLT2 inhibitors in patients with chronic kidney disease. 2 of these had already reported, both stopped early for benefit, Credence and DAPA-CKD. I presented some of the results of DAPA-CKD at the American Heart Association Congress, but in both of the 2 completed trials, there is no question that SGLT2 inhibitors reduce the risk of heart failure events in patients with chronic kidney disease. Probably no surprise there. But at the American Heart Association Congress, we saw the 3rd of the 4 big SGLT2 inhibitor CKD trials. That was the SCORED study with sotagliflozin, so this SGLT1/2 inhibitor again. This was intended to be a very big trial, but again, it ran into problems with the funding and with COVID-19, and the study was stopped early. But nevertheless, as you'll see in a moment, it showed some very interesting findings. Again, it was presented and published. It was published actually yesterday in the New England Journal of Medicine, and at least UK time. And here you can see the primary endpoint. So although this was a chronic kidney disease trial, it had a very short-term follow-up, really couldn't tell us much about end-stage kidney disease events because they take a long time to develop. And actually the primary endpoint in this chronic kidney disease trial was a cardiovascular endpoint, the same cardiovascular endpoint as in the SOLOIST worsening heart failure study. And as you can see here, again, a striking reduction in cardiovascular death or heart failure hospitalization. So that is now 3 trials in patients with chronic kidney disease showing a reduction in cardiovascular death or worsening heart failure events with 3 different drugs in this class. So clearly, unequivocally, cardiovascular and renal benefits with these drugs in patients with chronic kidney disease. But what was really, really remarkable in this study is shown on this slide, because here you see a secondary endpoint, and this is now looking at what you might call atherothrombotic or atherosclerotic endpoints. So cardiovascular death, non-fatal myocardial infarction, non-fatal stroke. You can see that this is reduced significantly by 23%. But for really the first time in a chronic kidney disease or heart failure trial. Here you can see a reduction in myocardial infarction and a reduction in stroke. Now, in the EMPA-REG outcome trial, there was a suggestion of a reduction in myocardial infarction, but as far as I know, no SGLT2 inhibitor trial has previously suggested a reduction in stroke with these drugs. So this really is an amazing additional piece of evidence about the cardiovascular benefits of these drugs in patients at risk of adverse cardiovascular outcomes. Then the very last thing I want to mention to you is another new chronic kidney disease trial with a new type of mineralocorticoid receptor antagonist. This is a so-called non-steroidal mineralocorticoid receptor antagonist, one that's believed to have more effect on the heart than maybe the kidney, one that is less likely, we hope, to cause hyperkalemia. And finerenone was studied in patients with type 2 diabetes and chronic kidney disease. In the Fidelio CKD trial, this trial had a primary renal endpoint, which was reduced significantly by finerenone. And as you can see here, there was also a reduction in this composite cardiovascular outcome. This was a key secondary endpoint, and Gerasimus Philippatis presented a further analysis of Fidelio DKD at the American Heart Association, looking at the benefit of finerenone in these patients with type 2 diabetes and chronic kidney disease, according to whether they had a background history of CVD or whether they had no history of CVD, showing an absolutely identical reduction in cardiovascular risk with no suggestion of a significant interaction. In other words, that the effect of finerenone was not modified by the existence of pre-existing cardiovascular disease. So now we've got two new types of drugs that reduce cardiovascular risk in patients with chronic kidney disease, at least in patients with chronic kidney disease and type 2 diabetes, an extraordinarily high-risk group of patients for whom we had only one proven therapy until literally a few weeks ago. And now in the space of a few weeks, we've got two new types of treatment, SGLT2 inhibitors and finerenone, that reduce cardiovascular risk. So with that, I'll finish and thank you very much. And I hope I got across some sense of what an exciting congress that was, with so much new and important information. Thank you very much.
Thank you, Dr. McMurray. I think, you did a great, scanning of the very, very important trials in the arena of heart failure, which was recently presented in AHA. And certainly we all are enlightened greatly by this presentation. And I'm sure there are questions by my co-chairperson, Dr. A.B. Mehta, and there are some other questions. But before we go on to the questions, I would like to certainly congratulate you for making such a nice capsule for us to digest and really understand the new data. So the only thing going back from your presentation is the very important data of chronic kidney disease and use of finerenone, which is kind of very fraught with problems of potassium elevation and stuff like that. So what do you think personally about this? Is it usable information as of now, and can we extrapolate this, because finerenone is still not available in India? So yeah. So how do we extrapolate this information for our day-to-day practice?
Well, I think the issues are obviously, is there something special about finerenone? Now, obviously, Bayer, who make finerenone, believe that there is, and they would argue that they developed this drug because they believed it was less likely to cause hyperkalemia. in patients with chronic kidney disease. And there's some evidence that that might be the case from earlier sort of, you might call phase 2 comparative studies with eplerenone and spironolactone. So if you accept those studies at face value, then I suppose the argument is that this is a drug that might have a better benefit risk profile for these patients, which you rightly identify as being at especially high risk for hyperkalemia. I mean, somebody who's got diabetes and chronic kidney disease, unquestionably there is a significant risk of hyperkalemia. So I suppose you could do two things. One is you could wait until finerenone becomes available, and I'm sure it will become available in the not too distant future because the results of that trial are pretty convincing. There is actually another second large trial called Figaro, which is currently underway, which should report next year. I imagine that trial will probably be positive as well. And if you have two huge positive trials, then I don't think there'll be any doubt that the drug will be approved. So one approach would be to wait and use the drug that's been shown to be effective and to be safe. The other approach, I suppose, you could use is I personally use eplerenone, I don't use spironolactone. You could use it, but with very careful monitoring. I mean, obviously, we have many patients with heart failure who have both the combination of diabetes and chronic kidney disease. And actually, in the trial that we did many years ago in heart failure called Emphasis Heart Failure, we found that by and large, eplerenone was well tolerated. So in most patients, if you used eplerenone, I think you would be okay. But that's the problem. You have to watch, you have to monitor, you have to bring them back, you have to check. And you, I think, as I said, generally will probably be all right, but no question, occasionally you do see a patient who gets into trouble, and then you have to be prepared, obviously, to either reduce the dose or even stop therapy. So in my patients like that who've got heart failure, I do use eplerenone. I will almost always try it, but sometimes I have to admit I do have to stop. But it's not that much. I mean, it's maybe 1 in 5 people possibly I have to stop treatment. It's certainly not a large fraction. It's definitely not the majority. But of course, the safer option might be to use the drug that's been tested outside the heart failure setting, and that drug is finerenone.
Thank you, Dr. McMurray. And Dr. Ashwin Mehta is here. He is one of the senior most cardiologists, I must say, and still very, very active and agile. So, Dr. Mehta, please, sir, you please give your thoughts in the new presentation. How do you will use all this in your own practice?
Right, Praveen, this was an excellent presentation, and he had made a bird's eye view of very important trials. But I came across one presentation which was done in AHA, and that who is more likely to use these varieties of drugs, including SGLT2, and we found that the cardiologists are using it the least. It is the physicians who are using it more. It looks like that I think cardiologists need to be educated to use these drugs more often. And the analysis was showing that hardly 2% of the cardiologists are using this drug.
Mm-hmm.
So I'm aware of these data. So I think that's a little, I don't think it's surprising. I think it's a little bit artificial because, of course, these drugs until very recently were primarily used to treat type 2 diabetes, not to treat heart failure. Yeah. So, of course, it was more likely that primary care physicians, internal medicine, general medicine physicians, and, of course, endocrinologists would use these drugs rather than cardiologists. But I think that is changing very fast indeed in the past 12 months. With the new evidence, but everything, you're absolutely right, everything takes time. We saw how long it took with sacubitril valsartan. I think it will be quicker with SGLT2 inhibitors because, as you say, a much broader group of doctors know about these drugs. They've already been exposed to them. They've heard of them. Many of them have used them. The problem, for example, with sacubitril valsartan was none of us had ever had it before. It was a completely new drug. SGLT2 inhibitors may be new to cardiologists, but as you've correctly pointed out, they're not that new to many other types of disease.
Yes, the endocrinologist and general physician.
Yeah, but I'm sure this survey must have been done maybe several months back, and I think the tables are turning to the other side. I see that more cardiologists are now using SGLT2 inhibitors.
Yeah, it's changing fast.
Yeah, my diabetes friends are more concentrating towards the GLP-1 agonist. So I mean, it's kind of changing, and I'm sure the use of SGLT2 inhibitors is going to increase tremendously in our practices.
True. Yeah. Okay.
So there are some questions, and there is a question here from Dr. Nishank from Mumbai. After 5-pillar therapy of heart failure, how do you see iron deficiency management in HF in light of AFFIRM-AHF? And also they asked this question, whether it would have met CV mortality endpoint.
Okay.
Dr. McMurray.
So I'll do the second one first because that's the easy one. So this trial did not show any reduction in cardiovascular mortality, but to be absolutely fair, the trial was not big enough or long enough to demonstrate a reduction in cardiovascular mortality. Remember, it was 1,100 patients and there was a fixed 12-month follow-up period. So there was simply not enough cardiovascular deaths to show a reduction in cardiovascular mortality. The trial only had statistical power to look at the composite and to look in particular at heart failure hospitalization. So there were only about 150 cardiovascular deaths in total. So we'll have to wait for some of the ongoing, larger, longer-term studies before we get definitive evidence about cardiovascular mortality. So where this trial has taken us forward is in relation to heart failure hospitalization. And I think there it does show a fairly convincing reduction of about 25% in heart failure hospitalization. So where do I think that fits with the pillars of therapy? Well, the pillars of therapy, the things that we give most weight to are things that reduce death. So we know that RAS blockade reduces death. We know that beta blockade reduces death. We know that neprilysin inhibition reduces death. We know that SGLT2 inhibitor reduces death. So those are our sort of key therapies. Then we have other therapies that are useful, very useful. So ivabradine reduces heart failure hospitalization. Digoxin reduces heart failure hospitalization. Vericiguat, which is another new drug, not yet available, reduces hospitalization. So those are valuable ancillary drugs. They probably also improve symptoms, and intravenous iron would fit in with those drugs. So valuable adjunctive therapies. I personally am a believer in intravenous iron. I use it in all my patients because I think improving symptoms is very important. And now that I know that it reduces hospitalization, that gives me even more reason to want to use it. So I think it's an important treatment. I think its guideline recommendation will be strengthened by the AFFIRM heart failure trial, but it won't be up there really at the top of the list yet because we don't know yet whether it reduces mortality.
So which means that one of other investigation in the battery of investigations apart from NT-proBNP levels in patients of heart failure, we will also have to start doing ferritin levels in these patients.
Ferritin and transferrin saturation,
yes, once in a year or something like that.
And I always do that. And in fact, our 2016 ESC guidelines did recommend that, although I know not everybody does do it.
Right. Okay, thank you. And there is last one more question. is there any trial on new trial on rosuvastatin? I'm sure you were doing on heart failure this time, but if you have any idea, you can tell us in the AHA.
No, well, we did 2 trials, as you know, with rosuvastatin in heart failure. So I was one of the people who led the Corona trial, which was in people with HFrEF of ischemic etiology. We randomized them to placebo or to rosuvastatin, and we did not reduce cardiovascular death or other endpoints. Our friends in Italy, the GC group, they did a trial with rosuvastatin as well called GC heart failure, and they did not see any reduction in events with rosuvastatin. So we have 2 large statin trials in patients with heart failure that showed no benefit. So I'm afraid the evidence, even though it's hard for us to believe, everybody expected statins to be good, but unfortunately the evidence is that if you've got heart failure, and indeed if you've got advanced chronic kidney disease, it seems as though statins are not of benefit. So heart failure and advanced chronic kidney disease are different. And the disease there is driven by other things. If you've got heart failure, MI and stroke are not actually that common. And it's actually sudden death, pump failure death, and worsening heart failure leading to hospital admission are really the key events. Those are the drivers, the determinants of your prognosis. And statins don't really affect those. They're not atherosclerotic events. And in any case, patients with heart failure, especially if they've got more advanced heart failure, have a very low cholesterol anyway. So the benefits of statins are a bit harder to show, I think, in patients with heart failure. And in 2 trials, we really fail to demonstrate any convincing benefits.
Yeah, one question is on the average dose was 2 vials in AFFIRM-AHF trial. So what is your take on this? Like 2 doses are okay, or one has to still measure the ferritin levels and titrate accordingly?
Well, I mean, in theory, you should follow the protocol used in the AFFIRM heart failure. So you're right, you should follow these patients up. We usually do follow these patients up. And again, if you have not corrected their ferritin, in particular the transferrin saturation, then you should treat them again. Although probably maybe around 2/3 of people don't actually need repeat transfusion, at least infusion, sorry, at least in our practice now. I don't know what it's like in India. Maybe it's different. Maybe there's a higher prevalence or maybe greater iron deficiency than we see, but we don't need to repeat intravenous iron therapy in a large proportion of our patients.
Okay, thank you. So I think with this, we can probably, if there are no more questions, Dr. Mehta, do you have any
No, thank you.
about anything?
No.
Otherwise, we can.
Yes,
go ahead
Praveen.
with yeah, please.
Yeah.
Thank you.
Thank you.
Thank you so much.
So maybe you can introduce the second speaker.
Yeah, I'm waiting for the slide. Right. Our second speaker for today's evening is Dr. Peter Pito. He's the Director of Preventive Cardiology at CGH Medical Center in Sterling, Illinois, and Professor of Clinical Family and Community Medicine at the University of Illinois College of Medicine in Peoria. And I get nostalgic, Dr. Peter, too, about Peoria, because for 3 years I was working at University of Illinois at Chicago at Medical Center, and we used to get patients from Peoria, especially the babies. Dr. To has authored and co-authored more than 220 publications in scientific journals, which are peer-reviewed journals, and textbooks. He is the co-editor of the textbook Comprehensive Management of High-Risk Cardiovascular Patients, and I think therefore he aptly deserves this particular talk, from which we all expect to benefit a lot. So without going into more details, because his biodata his curriculum vitae is fairly big. And before I spend some more time on this, let us spend time on Dr. To's talk. Dr. Peter To, please.
Thank you, Dr. Mehta. So good to be with all of you here this evening. And I appreciate being invited to give this talk tonight. I'm going to share my screen. Dr. Mehta, can you see my screen?
Yes, we can. Yes.
Okay, so my talk will be very different. This will be more of a potpourri of sorts, looking at a broad range of clinical trial and new information across the spectrum of heart disease. And what we'll do is we will begin with the AFFIRM trial. This was performed in Europe and assessed the loading with the P2Y12 inhibitor ticagrelor versus clopidogrel to halt ischemic events in patients undergoing elective coronary stenting. So, of course, everyone on this teleconference understands very well that PCI is generally quite safe. And when it's performed in an elective setting in stable coronary patients, there's less than 1% serious complications. But we do have a problem, and that is that PCI-related MI and myocardial injury can be frequently diagnosed after the PCI. And myocardial necrosis in the periprocedural period is an adverse prognostic indicator. Studies have demonstrated that patients have a better prognosis in the absence of such periprocedural myonecrosis. And it was hypothesized that a stronger platelet inhibitor, in this case ticagrelor, could potentially lower these events and make the procedure safer. So here we see the study design. 1,900 patients who were troponin negative or modestly positive, but scheduled for elective PCI, are randomized to ticagrelor versus clopidogrel. And of course, ticagrelor did outperform clopidogrel in the Plato trial, which made this a very legitimate comparison to see if there's superiority. The study was performed in France and the Czech Republic, and the primary endpoint would be MI secondary to stent thrombosis or major myocardial injury at 48 hours after discharge. Patients are followed for 30 days for clinically important secondary endpoints. So here we see the inclusion criteria, which I think are quite reasonable. And then patients also had to have at least one other high-risk feature, which you see in the two text boxes on the right. Key exclusions included an ACES, need for chronic oral anticoagulation, or other planned coronary revascularization within 30 days. So the trial was disappointing, as we see here. The odds ratio for the primary outcome and then for pre-specified secondary outcomes, including myocardial infarction, stent thrombosis, and major myocardial injury, odds ratios hugged 1. There was absolutely no between group differences, and hence ticagrelor was not superior, and of course clopidogrel was not inferior. So the investigators concluded that in fact a higher level of platelet inhibition, as you would expect from ticagrelor, does not translate into a reduction of periprocedural MI or myocardial injury within 48 hours of high-risk PCI performed in stable coronary patients. None of the clinical outcomes differed between groups at 30 days of follow-up, and ticagrelor use for 30 days did not translate into, However, there was a downside, and that was that ticagrelor use for 30 days did associate with an excess of minor bleeding and dyspnea, but it did not result in an increase in major bleeding. So I think this trial was counterintuitive, but the data are what they are, and hence continuing to use clopidogrel with aspirin is a very reasonable approach for patients who are undergoing elective PCI. Now, how about clinical lipidology? All of you know that things are changing in lipidology. There are many new drugs coming online, and we know that LDL and non-HDL targets are going ever lower. I'm a major fan of the European guidelines for the management of dyslipidemia because they are so aggressive. And when we look at our highest risk patients who sustain a secondary event within 2 years of the previous one, taking an LDL to 40 or less, I think scares some people. But I'll tell you that there is absolutely no evidence to suggest that there is cause for concern in taking LDL ever lower. And why is that? Because there's really nothing you do with LDL. LDL is essentially spent garbage lipid, and it's not like your systemic tissues take cholesterol out of LDL particles and burn it as fuel, because no eukaryotic cell other than the liver or steroidogenic tissue is able to convert cholesterol to a different metabolite. And hence, the better you are at getting rid of LDL cholesterol, the lower your risk. And there appears to be no lower threshold. And I think consistent with the recent Ebbinghaus trial, even ultra low LDL less than 10 milligrams per deciliter does not result in any increase in risk for neurocognitive impairment. And this is because your brain regulates all of its own cholesterol biosynthesis. It has its own apolipoprotein and lipoprotein metabolism, and lipoproteins do not cross the blood-brain barrier. The only excretory sterol product emanating from the brain is 24S-hydroxycholesterol, but the half-life of cholesterol is 7.5 years in your brain, and oligodendrocytes and astrocytes do a wonderful job of maintaining appropriate cholesterol levels, both for myelin biosynthesis as well as for normal cellular function. So the buzzword now is, when it comes to LDL, lower is better, but lowest is best. And in that spirit, let's begin with a study with bempedoic acid. Now, bempedoic acid is approved within the United States, and it is what we call an ATP citrate lyase inhibitor. I'll tell you about that in just a moment. But of course, statins decrease cardiovascular event rates. Basically, any approach that lowers LDL, a vascular toxin, decreases risk for future cardiovascular events. However, I know very well, because I've been to India 11 times now. In India, there is considerable concern about statin side effects. I know that many Indian doctors hesitate to titrate statins very aggressively, and if they start a patient out on a high-dose, high-potency statin, they frequently down titrate after a patient has had a very appropriate LDL reduction. But just know that when we do this, when we down titrate, especially when it's unnecessary, we leave LDL higher than it should be, and we leave the patient exposed to excess risk. So I think when we talk about residual risk, we're actually talking in many cases about not lowering LDL enough. It's not that we haven't raised HDL, which we know is therapeutically not appropriate. It's not that we haven't lowered triglycerides enough. It's that we haven't lowered the burden of atherogenic lipoprotein in serum enough. Now, there's no question there are some patients who don't tolerate high doses of statins. There are patients who are statin intolerant. But as we saw in a paper in the New England Journal of Medicine this week out of England, in fact, the vast majority of patients who claim to be statin intolerant actually have the nocebo effect, because they're also intolerant of placebo pills. So this is a quandary. I know that it's a clinically significant issue, but this is also why it's important to have other pharmacologic interventions available to us, so that if a patient truly believes that they're statin intolerant, we can provide them with other forms of therapy. Oral options that further lower LDL are in fact quite useful. We know that the PCSK9 monoclonals are quite expensive. Inclisiran, another injectable, but which is going to be a silencing RNA type technology, that will likely also be expensive. And some patients don't like the idea of an injection. So having other oral molecules available that provide either significant LDL reduction or incremental LDL reduction over and above a statin, these are important to continue to have and to continue to develop. So what is exactly this molecule? Well, it's absorbed through the small intestine. It's got a half-life of 15 to 24 hours, and it's a prodrug. It is converted within the liver to its coenzyme A thioester via an enzyme called very long-chain acyl-CoA synthetase 1. And the active metabolite is the one responsible for competitive inhibition of ATP citrate lyase. So what does that enzyme do? ATP citrate lyase is an enzyme that lies upstream from the rate-limiting step of cholesterol biosynthesis, which is HMG-CoA reductase. And ATP citrate lyase is an enzymatic mechanism by which carbohydrate and lipid metabolism are integrated. So citrate is the first metabolite within the Krebs cycle, and it's formed by the condensation of acetyl-CoA with oxaloacetate. Well, what ATP citrate lyase does is it regenerates acetyl-CoA from citrate. And this is an energy-dependent process, which is why it consumes ATP. But it very efficiently regenerates acetyl coenzyme A, which can then be shunted toward either fatty acid biosynthesis or cholesterol biosynthesis. And ATP citrate lyase inhibition has in fact turned out to be a very appropriate molecular target for reducing LDL cholesterol production, as well as increasing its uptake, because when ATP citrate lyase is inhibited, LDL receptor expression on the hepatocyte surface is increased. This molecule is inactivated by glucuronidation, and it's about 70% excreted in urine. And of course, glucuronidation helps to solubilize a molecule and promote its systemic elimination. And because it is a glucuronidated molecule, it's critically important that if you have a patient who has concomitant hypertriglyceridemia, you not combine bempedoic acid with gemfibrozil, because gemfibrozil does inhibit two of the three most important UDP-dependent glucuronyl transferases responsible for glucuronidating lipid-lowering agents such as bempedoate and ezetimibe, just by way of example. So what does it do? Well, it does provide 15 to 25% reductions in LDL cholesterol, 15 to 21% reductions in non-HDL. It decreases ApoB. It reduces hsCRP by about 24%. And these reductions are seen by week 4 to 6 after initiating therapy. And these reductions are maintained for up to a year in clinical trials. There have been a number of studies that have been reported out. Clear Harmony evaluated safety and efficacy over 52 weeks. Clear Wisdom, similarly. This drug is being tested in a very interesting cardiovascular outcomes trial called Clear Outcomes. And it has enrolled about 14,500 patients, but everyone in the trial is statin intolerant. And so the only drug that they're going to be treated with is bempedoic acid. The trial is fully enrolled and is expected to report out in the fourth quarter of 2023. So this will be a very interesting trial. It will also be interesting to see if a 18 to 20% or so reduction in LDL independent of statin background therapy is enough to provide reductions in risk for acute cardiovascular events in high-risk patients. Okay, so just to summarize, bempedoate is a once-daily first-in-class small molecule that lowers LDL cholesterol by inhibiting ATP citrate lyase. And this enzyme lies 2 steps upstream from HMG-CoA reductase. Bempedoate is a prodrug. It has to be converted to its coenzyme A thioester in order to be active. but this enzyme is also only expressed in the liver. It is not expressed in skeletal muscle or other tissues, and hence it is hoped that this may provide some benefit in terms of a lower risk for skeletal muscle related side effects. LDL reduction can range from 15 to 25%. It's been well tolerated, and a cardiovascular outcomes trial is underway. Okay, so how about evinacumab? Well, this is an amazing development. The angiopoietin-like proteins are a very large family of proteins that exert regulatory effects over a variety of enzymes. And there are two angiopoietin-like proteins, namely 3 and 4, that are extremely important to the regulation of triglyceride metabolism because they regulate the activity of the enzyme lipoprotein lipase, which is in your plasma. Of course, when your liver secretes triglyceride-enriched lipoproteins, this is the high-energy form of a lipoprotein, and it is the role of a VLDL particle to distribute fatty acids, triglycerides to systemic tissues to drive oxidative metabolism and intermediary metabolism. And the only way this can happen is if lipoprotein lipase is actively hydrolyzing the triglycerides in the core of these triglyceride-enriched lipoproteins, releasing the free fatty acid. Angiopoietin-like proteins 3 and 4 both inhibit lipoprotein lipase. And to give you a feel for just how complex this regulation can be, we know that apoprotein C3 inhibits lipoprotein lipase, apoprotein C2 activates it. And angiopoietin-like protein 3 is a direct inhibitor of lipoprotein lipase, meaning it interferes with the active site of the enzyme. And angiopoietin-like protein 4 is really, really interesting because lipoprotein lipase is comprised of multiple subunits held together by disulfide bridges, and angiopoietin-like protein 4 dissociates those disulfide bridges and dissociates the enzyme into its individual subunits. So very different mechanisms of action. So clearly lipoprotein lipase is also at a crossroads in terms of lipid and lipoprotein metabolism. It's a critically important enzyme. And when you inhibit it, the patient is going to have impaired capacity for VLDL and remnant lipoprotein lipolysis. Their triglycerides will be high. And actually more and more data from around the world, from prospective longitudinal cohorts in Europe, the United States, in Asia, in South America, clearly show that remnant lipoproteins like small VLDLs, IDLs, or intermediate density lipoprotein, they are in fact not only atherogenic, but correlate with heightened risk for acute cardiovascular events. At least in the REDUCE-IT trial, we found that that identifying patients with hypertriglyceridemia did provide some benefit in terms of endpoint reduction when they were treated with an omega-3 fatty acid. And so what is evinacumab? Evinacumab is a monoclonal antibody directed against angiopoietin-like protein 3. And this gets really, really interesting because when you inhibit angiopoietin-like protein 3, not only do you allow for the activation of lipoprotein lipase and a dramatic reduction of 70 to 90% in serum triglycerides, but you also lower LDL. Now, that is not intuitively obvious as to why that would be, because actually, if anything, I would expect LDL to go up because now you've opened the floodgates. You've activated lipoprotein lipase. The patient has hypertriglyceridemia. They have large amounts of VLDL. And as you promote the lipolysis of VLDL to IDL, the IDL is converted to LDL. So LDL should go up, right? That's not what happens. And this is because somehow the evinacumab also dramatically upregulates the expression of VLDL and remnant lipoprotein receptors on the surface of the hepatocyte, promoting the clearance of smaller VLDLs and IDLs. And of course, this means that those particles will not be converted to LDL in serum. Now, mechanistically, how this happens is still not known, but this is what is observed. So what do you see? Well, this is really amazing because what they did was, and this is reported in the New England Journal of Medicine this week, in 142 persons who were healthy or with mild hypertriglyceridemia, as I mentioned, evinacumab reduces triglycerides by, it's actually 70 to 90%. In a study of 9 individuals with homozygous FH, evinacumab reduces LDL by 49%, making evinacumab potentially one of the most efficacious treatment options for homozygous FH. You know, it's interesting, evolocumab, a PCSK9 monoclonal, reduces LDL about 31% in homozygotes. And then you have other drugs like myosin, and they don't give near the level of LDL reduction that you're seeing here. And in order to see significant LDL reduction without agents like this, if you combine a statin with ezetimibe and whatever else you want, you still cannot approach what you're seeing here. So this really is a tremendous breakthrough in terms of patients with FH, but also patients with hypertriglyceridemia. So we'll see how things go. Hopefully this drug will be approved very quickly. And they have ongoing phase 2 and phase 3 trials investigating long-term safety and efficacy in patients with triglycerides over 1,000, which would be consistent with familial hyperchylomicronemia syndrome, and also in patients with homozygous familial hypercholesterolemia. So exciting times with evinacumab. Okay, the poly pill. Now, Dr. Salim Youssef has been a very strong proponent of the poly pill. And the poly pill that they investigated here in this particular trial, which is also published in the New England Journal of Medicine this week, contains simvastatin at 40 milligrams, hydrochlorothiazide at 25 milligrams, atenolol at 100 milligrams, and 10 milligrams of ramipril. Now, granted, everyone doesn't need all 3 of those antihypertensive medications. And there is talk of developing variations of a poly pill, but this is a real proof of concept that Dr. Youssef and co-workers have done here when they explored aspirin alone or in combination with a poly pill and its impact on risk for acute cardiovascular events. So in the first part of this trial, they explored the impact of aspirin versus placebo and looked at primary, secondary events, first and recurrent events. And then they also looked at the impact of a poly pill plus aspirin versus double placebo. And you see the endpoints here for both primary, secondary, and then first and recurrent events. Now, the data are pretty impressive, actually. Not so much for aspirin versus placebo. Here, you notice that the primary composite endpoint, cardiovascular mortality, MI, no benefit, but stroke was reduced by 42% and statistically significant. First and recurrent primary events, cancer, impact on mortality. There are trends. There are definitely trends. And you notice that this trial is not huge in terms of just under 3,000 patients per arm. I think had they used higher risk patients and a larger number of patients, perhaps you would have seen stronger impact on these hazard ratios, and perhaps you would have seen some more statistically significant results. But the trends are definitely there despite the lack of statistical significance. But I think a 42% reduction in stroke absolutely is very impressive. Now, how about when we look at the poly pill plus aspirin versus double placebo? So here we see plotted double placebo in red, the aspirin alone in the light blue, the poly pill only in black, but then the poly pill plus aspirin. Wow, that is going to be a substantial difference. Overall, we see that the poly pill plus aspirin compared to placebo for the primary composite endpoint reduced event rates by 31%, statistically significant. And we also see that cardiovascular death, MI, stroke, which is your usual primary composite endpoint, 32% reduction, statistically significant. Primary endpoint plus angina, 31% reduction, statistically significant. First and recurrent primary events, 32%, statistically significant. Now, this is really interesting, and I can't really say too much here. I don't think anyone can, but CVD plus cancer, 30% statistically significant. And when you look at trends, 22% reduction, not significant. Mortality, 20%, not significant. Again, small study, only 1,420 patients or so per arm. I think it's amazing that there's a trend for cancer reduction. I don't know why. It may be a spurious finding, a chance finding, but definitely worth exploring in a bigger study. And then definitely a trend for mortality that unfortunately did not hit. But again, it's not a very big study. Now, when you look at individual endpoints, you see here that stroke hit at a very substantial 58% reduction. And then CV death, MI, heart failure, revasc, angina, with the exception of heart failure, all have substantive trends, but did not hit statistically significantly. So what's amazing is this was an intermediate risk population without CVD. They're followed for 4.6 years, relatively modestly sized study. And they were able to observe a 21% reduction in CVD with the polypill alone, 14% with aspirin. And there's a somewhat additive effect between polypill and aspirin, a 31% reduction in CVD. Benefits were larger in those without discontinuation for non-medical reasons. So that was 40%. And aspirin did appear to contribute importantly to benefit with a major reduction in risk of stroke in the monotherapy arm. I don't think 30 to 40% reductions in CVD with a polypill and aspirin is modest. I think that's quite substantial. And if half of eligible people used a polypill with aspirin, 3 to 5 million CVD events could be avoided globally every year. And it's likely a cost-effective strategy to meet global targets of reducing CVD by 30% by 2030. And remember, all the medications in this polypill are generic and could be produced on a mass scale relatively inexpensively. And then, of course, you could also tailor additional types of polypills that would give you greater or lesser reductions in LDL, greater or lesser reductions in blood pressure. And I think this has major, major global health implications. Now, how about salt sensitivity? This really gets wild. I find work on the gut and the microbiota absolutely fascinating. And although a lot of it is still in its infancy, we're learning a lot about how the gut regulates so many processes because it is cohabited by so many types of gut flora. And different balance among different microbiota, different flora, gram-negative, gram-positive, aerobic, anaerobic bacteria regulate level of systemic inflammatory tone. They can regulate very specific types of metabolites that are being absorbed. They can regulate endothelial function and dysfunction throughout the gastrointestinal system. The list is very long, and the metabolism of the gut in terms of how microbiota regulate all these processes is just astounding, and it's vast, and we're just learning. But let's take a crack at this because it's very interesting. So, of course, salt is absorbed through the gut, and we all know that a high salt diet is deleterious in terms of raising blood pressure, expanding intravascular volume, stressing the kidney, and where salt absorbed in the GI tract. And the gut and the gut microbiota regulate a vast array of immune-dependent and immune-independent processes that actually have systemic implications. And high salt diet with excess salt absorption clearly is related to elevations in blood pressure. And we know that restricting salt and the DASH diet, etc., are both beneficial. So it turns out that excess salt is associated with an increase in gut microbiome toxin production, which leads to an increase in enterocyte inflammation, which leads to endothelial dysfunction in the gut vasculature. And this can lead to an increase in reactive oxygen species elaboration, which stresses dendritic cells, which then increase their production of interleukins 1 and 6, which leads to T helper cell activation, which then amplifies the inflammatory response and leads to an increase in production of interferon gamma, tumor necrosis factor alpha, interleukin 17, all of which can lead to heightened systemic inflammatory tone, endothelial dysfunction, a reduction in endothelial nitric oxide production, increases in endothelin 1, and reductions in bradykinin, as well as prostacyclin, which of course can lead to hypertension. Interesting. And so it turns out that for the recommendation by guideline writing bodies of increasing dietary fiber, there's some method to the madness here, because commensal bacteria can convert components of fiber into very beneficial short-chain fatty acids, which include acetate, propionate, and butyrate. And it turns out that these short-chain fatty acids are anti-inflammatory. They have very, very specific cell surface receptors on such cells as T helper cells and dendritic cells, and they help to cool inflammatory tone. It also leads to a reduction in local gut inflammation, which can lead to less absorption of microbiota-related toxins that feed atherogenesis. Interesting. So bottom line here is that the salt-sensitive form of hypertension, it's not so simple as just salt impacting intravascular volume and leading to a direct increase in blood pressure. It's actually dependent on a lot of what happens within the gut lumen and what the gut flora are doing metabolically. So what does the high dietary fiber do? Well, it turns out that high dietary fiber actually reduces the intestinal excretion, absorption of sodium. And so, I'm sorry, I didn't say that quite right. It increases intestinal excretion, reduces the absorption of sodium by reducing the population size of Bacteroides fragilis. This leads to a reduction in arachidonic acid. If intestinal corticosterone increases, blood pressure goes up. And if you look at immune-dependent processes, when the lactobacilli are reduced, indole 3 lactate is increased, and this leads to an activation of T helper cells, an increase in intestinal inflammation, and blood pressure rises. Dietary fiber intake helps to attenuate both of these responses. Now, how about potassium enrichment as a salt substitute? So most of the newer blood pressure guidelines contain recommendations on potassium because substituting potassium for sodium does have modest impact on blood pressure. It reduces it. So what are some of the basics for salt substitution? Regular salt, of course, is 100% sodium chloride. Potassium-enriched salt substitutes replace some sodium and sometimes with some magnesium and calcium. And the typical composition is 3/4 sodium, 1/4 potassium. We know in population-wide studies, reduced sodium, increased potassium lowers blood pressure and lowers risk for CVD. Potential harms include kidney disease, an increase in serum potassium, risk of hyperkalemia, though that appears to be quite modest. And in patients who are vulnerable to development of severe hyperkalemia, it can result in arrhythmias and cardiac sudden death. So when you look at salt substitution with potassium, what do you see? Well, overall, you see reductions of both systolic and diastolic blood pressure. And remember, based on the HOPE trial, even a blood pressure reduction of 3/2 was enough to cause a difference between groups in terms of outcomes. And here you're looking at, on average, a 5/1.5 millimeters of mercury reduction in blood pressure. And among patients with hypertension, it's slightly more at 5.7 over 2.4. And in normotensive patients, it's less at 2.7 over 1.3 millimeters of mercury. So one concern is the hyperkalemia. There are numerous cases of life-threatening hyperkalemia, most in the setting of risk factors for hyperkalemia. One fatality attributed to suicide from intentional overdose. There's sparse evidence on the effects of potassium-enriched substitutes on serum potassium and incident hyperkalemia in persons with chronic kidney disease. And if you look at data from China, elevated blood pressure caused 2.3 million deaths in China during 2015, mainly from cardiovascular disease, and intake of sodium is high in China, estimated to cause 1 in 7 CVD deaths, mainly from salt added in cooking or at the table. Intake of potassium is low. So we know that potassium-enriched salt substitutes lower blood pressure. There is great potential benefit to prevent blood pressure-related CVD in China and other Southeast Asian countries where sodium intake is high, potassium intake is low. Most sodium comes from salt added during cooking and at the table. And concern about hyperkalemia in patients with impaired ability to excrete potassium, particularly persons with chronic kidney disease. But that risk appears to be low, and obviously you would have to look at background medications that might be either wasting potassium or causing potassium retention, such as mineralocorticoid receptor antagonists. All right, so that takes us to the RIVER trial. And RIVER is very interesting and a much needed trial. We know that patients with atrial fibrillation of a bioprosthetic mitral valve require long-term anticoagulation, but the optimal therapeutic strategy remains uncertain. The efficacy and safety of the DOACs in patients with atrial fibrillation in a mitral bioprosthetic valve are based on subgroup analyses of pivotal trials, such as Aristotle and Engage-TIMI 48. But remember, in Aristotle, there were only 31 patients, Engage-TIMI 48, 131. Patients with bioprosthetic valves were excluded from the ROCKET-AF trial. So how was the study performed? Patients with atrial fibrillation or flutter and a bioprosthetic mitral valve were randomized to either rivaroxaban at 20 milligrams daily or a reduced rate with stage 3 A or B CKD versus warfarin, keeping the INR between 2 and 3. The study was intended to show that rivaroxaban was non-inferior to warfarin. Primary endpoint is death, major CV events, or major bleeding. And major CV events included stroke, TIA, valve thrombosis, systemic embolism, not related to the central nervous system, or hospitalization or heart failure. And here's the statistical analysis. The primary endpoint analysis was restricted mean survival time, which is the mean time free from an outcome event up to a year, reflecting the area under the survival curve, as we see on the left. And the sample size was intended to show that the rivaroxaban was non-inferior to the warfarin. 80% power, predicted event rate or expected event rate of 14.5% warfarin group, the hazard ratio of 0.79, alpha level 5%. And we see that the effect was pretty substantial. This is very impressive. Time for mitral valve implantation less than 3 months. Here's the primary endpoint, reduced by 69%. And you notice that these Kaplan-Meier survival curves are separating progressively more as a function of time, and they separated virtually immediately. So clearly, the rivaroxaban was not inferior to warfarin and does appear to provide substantially greater protection from death, major CV events, or major bleeding. So to conclude, in patients with atrial fibrillation and bioprosthetic mitral valve, rivaroxaban is not inferior to warfarin with respect to mean time free from death, major CV events, or major bleeding. And since rivaroxaban does not require monitoring and has a more consistent anticoagulant effect, it's less influenced by food or concomitant medications and represents an attractive alternative to warfarin for this patient population. That takes us to strength. Oh, was disappointing? So, of course, strength looked at the impact of high-dose omega-3 fatty acids. And this, of course, was a combination therapy between EPA and DHA. And they compared combination omega-3 fatty acid therapy to corn oil on major adverse cardiovascular events in patients with high cardiovascular risk. And, of course, everyone in this trial was on background statin therapy. We know that Reduce-It was, in fact, quite positive, but Reduce-It only used highly purified icosapent ethyl, or EPA. We also know that there have been at least 12 clinical trials in the last 20 years using EPA-DHA, looking at a variety of cardiovascular endpoints, and they have been negative. And one of the big criticisms of many of those trials was that the omega-3s were underdosed. Well, we know that 4 grams daily in Reduce-It worked, and so they used 4 grams daily again, but this time split between EPA, or icosapentaenoic acid, and DHA, or docosahexaenoic acid. And they used, in this particular trial, the omega-3 carboxylic acid formulation because it doesn't require pancreatic lipase for absorption and has enhanced bioavailability to achieve higher and more reliable blood levels of both EPA and DHA. The corn oil was deliberately selected as a placebo since olive oil likely is a positive control and mineral oil a negative control. That's absolutely not true. The FDA has already ruled on this, and they did not deem mineral oil to be a negative control. And they enrolled statin-treated patients with or at high risk for cardiovascular disease with triglycerides 180 to 500, HDL less than 42 in men or 47 in women. So, amazingly, these Kaplan-Meier survival curves are beautifully superimposable. There is absolutely no effect either way. And after 4.5 years, they called the trial due to futility. There's absolutely no impact on cardiovascular death, MI, stroke, coronary revasc, or hospitalization for unstable angina. Now, something that was observed in Reduce-It was an increase in risk for atrial fibrillation. And it was unclear if that was a spurious finding or not. But in strength, although there was no impact on the primary composite endpoint, there was an increase in the hazard for atrial fibrillation. So obviously, this is something that needs to be explored further. And, you know, this is actually pretty significant. And is the size effect unique to combination EPA-DHA? I don't know. But bottom line here is, a big question is, why did EPA work and why does EPA with DHA never work? Well, good question. And so it turns out that EPA is an upstream substrate for a whole new class of molecules called resolvins. And there's a number of resolvins, and they have specific cell surface receptors on inflammatory cells, and they actually actively inhibit the inflammatory response. So in this situation, the inflammatory response doesn't just somehow burn out. This is an active attenuation of the inflammatory response. And E1, E2, E3 are all intensively being evaluated because their power to attenuate inflammation is startling. Now, DHA also participates in resolution of inflammation through molecules that are not only resolvins, but also protectins. And they also produce a family of molecules that can impact macrophage activity. But for some reason, you're just not seeing benefit. And it's not clear if there's something else that the DHA is doing to completely offset the benefit of EPA. I'm not sure this question will ever be answered because I don't think you're going to see too many more trials performed with the omega-3s. But bottom line is this is a stark contrast to what we saw in the REDUCE-IT trial. And so the investigators concluded that the administration of omega-3 carboxylic acids at 4 grams daily compared with corn oil did not reduce the incidence of major adverse cardiovascular events. The study was shut down early due to futility. The lack of benefit occurred despite a 269% increase in plasma EPA. But I will tell you that in this particular trial, because they used only 2 grams instead of 4 grams, they only reached an EPA level in serum of 89.6 micrograms per liter, whereas in the REDUCE-IT trial, they reached a level that was 144 micrograms of EPA per milliliter. So could that have explained some of the difference? I don't know. Compared with mineral oil used in the REDUCE-IT trial, corn oil did not raise LDL, ApoB, or HSCRP, suggesting that it was a truly neutral comparator. To this I say, whatever, the FDA already ruled on this. And these findings in the context of the increased risk of atrial fibrillation seen in this and other omega-3 trials cast uncertainty regarding whether there is net benefit or harm with any omega-3 fatty acid preparation. This is nonsense because we already know that in REDUCE-IT, the primary composite endpoint was reduced by 25%. And despite a signal for atrial fibrillation, sudden death was reduced by 53%. There was no increase in risk of stroke. In fact, stroke was reduced by 27% in the REDUCE-IT trial. And all endpoints, even cardiovascular mortality, was reduced in a statistically significant way in REDUCE-IT. So this final comment on the part of the strength investigators is a little nonsensical to me. All right, and that takes us to the last study presented at AHA that I'm going to discuss, and that's Pioneer 3. Now, I know that there's a lot of very, very, very smart, capable interventional cardiologists on this call. And so I really don't need to talk about different drug coatings that inhibit smooth muscle cell proliferation, neointimalization. But we all know for darn sure that maintaining good endothelial function, that promoting reendothelialization without excess smooth muscle cell infiltration and clonal expansion are critically important to maintaining good stent function and patency. So this Pioneer 3, I recommend that you actually read the paper, do some background on the layering of this stent because it's very complicated. It's an amazing innovation. I think I'm not an interventional cardiologist, but I have a strong interest in neointimalization and endothelial functional integrity. So bottom line in Pioneer 3, just by way of background, polymer-based drug-eluting stents are associated with chronic inflammation and delayed vessel healing. Of course, it's a foreign body, and this contributes to an annual 2-3% late DES failure and life-threatening stent thrombosis. Obviously a problem. The supreme healing targeted DES, it's Sinomed, emphasizes early restoration of endothelial function to minimize chronic inflammation via rapid drug delivery and polymer degradation rather than the typical prolonged suppression of smooth muscle cell proliferation and polymer exposure. And a biostable base layer that promotes endothelial migration and healing and protects the underlying metallic stent from chronic corrosion and ion leaching. There are papers in the literature on this. There are also some absolutely beautiful figures demonstrating how they layer this stent. It is remarkable. They have my respect. So here's how Pioneer 3 was designed. Patients are randomized 2-to-1 to the Supreme HT-DES versus the Xience Promis DP-DES, 1,088 in the Supreme stent group versus 544 on the Xience Promis. Primary endpoint is cardiac death, target vessel MI, IDTLR at 12 months. We see the other secondary endpoints here. And by the way, the trial is not yet completed. It's going to go 5 years. What you're looking at here is 1-year data. So in terms of the primary endpoint, you're not seeing any difference. But in terms of composite secondary endpoints, cardiac death or target vessel MI, you are seeing a nominal shift that is not statistically significant. Obviously, it's 1-year data. The study's supposed to go 5 years. We'll see. But bottom line here is that it shows some promise, and I think it's very interesting. Obviously, we have 4 years to go. And so the investigators for Pioneer 3 concluded that based on their 1-year data, among patients with acute and chronic coronary syndromes undergoing PCI, the novel stent was as safe and effective as the standardized DES. Safety measures of CV death and MI and late ST numerically favor the HT DES compared to the DP. And whether these early safety measures translate into significant clinical benefit in the longer term, of course, has to be evaluated at 5 years of follow-up. And so that is the potpourri for today. Again, I want to thank my friends in India for inviting me to do this. It's always wonderful to be with you. And thank you.
Thank you, Dr. Toth. That was, again, very, very enriching information for all of us here in India. Without attending the HA, now we can quickly have this capsule and start using it for daily clinical practice. And of course, the data which you presented on this new drug on reducing cholesterol, I think this is, up till now, statins were the only drug apart from ezetimibe, which is which initially had its issues. Now we are using it more commonly, but now with this new drug, I think still I think little bit far away from using it in daily routine practice, because I don't know whether it is still available anywhere in the world or is just out of the trial right now. Any information on that, Dr. Toth? Is it available anywhere?
Are you talking about the bempedoic acid
yes,
now?
Bempedoic acid, yeah.
Bempedoic acid is approved in the United States. It's available as bempedoic acid monotherapy, but also as a combination pill with ezetimibe. I believe that the European drug agency is either in the process of approving it or has approved it. Perhaps Dr. McMurray knows that better than I do.
I'm sorry, I don't.
Yeah. So, and in South America, it's on the verge of approval. So, I'm sure it's going to find its way to India.
Okay, thank you. Dr. Mehta, please. Your mic is muted, Dr. Mehta.
Okay, Dr. To,
Yes.
probably it might sound very naive question, but I think we've been in India, we have a pattern our lipid pattern is associated with moderate elevation of total cholesterol, moderate elevation of triglycerides, invariably low HDL, and mild elevation of LDL, mild to moderate. Now, this is a typical Indian pattern, and we've been emphasizing when you cannot alter HDL, which I think could affect the outcome favorably. Are you aware of importance of HDL in relation to LDL, or importance of HDL per se on its own? Will you place the HDL anywhere in your therapeutic armamentarium, or will you give any importance to HDL?
Well, we haven't cracked the HDL code yet, Dr. Mehta. The problem is that unlike other lipoproteins, which I'm not going to use the word simple, but they are simpler, because HDL has a very complex proteome and lipidome. It can carry up to 300 different kinds of proteins, globulins, enzymes. It carries up to 37 different microRNAs, which we know regulate cell function. It has up to 57 different lipids that can comprise the particle, and that's just starters. Now, these things can vary as a function of the metabolic milieu. If a patient has chronic kidney disease, underlying coronary disease, insulin resistance, diabetes, or a combination thereof, that alters the biochemical constituency of HDL. We know in a very limited way that if you treat patients with cholesterol ester transfer protein inhibitors or with niacin and raise HDL substantially with those agents, you do not observe cardiovascular benefit. What we have seen with infusible HDL mimetics is that infusible HDL mimetics do delipidate established coronary and carotid plaque based on imaging studies. But these drugs are extremely expensive, and no one has yet been able to perform an outcomes trial using mimetics. So we don't know if that plaque delipidation will ultimately correlate with reductions in cardiovascular events. So at the present time, no clinical guideline recommends therapeutic intervention for low HDL. When you look at dietary studies, exercise studies, yes, they can raise HDL, but ultimately dietary and exercise studies do not go long enough in order to determine through multivariate regression whether or not that HDL elevation impacted events. So right now, the name of the game is to reduce atherogenic lipoprotein burden in serum as much as possible, not worry about HDL, and we know with certainty that this impacts risk for cardiovascular events.
One more question, Dr. Peter Toe. In your practice, people who have moderate risk to develop future coronary event, but are healthy otherwise, and who in them, what will be your target? To what level would you like to reduce? And at what particular dose you will say that, well, I think enough is enough?
Okay, that's a great question. And let me just start with what the ideal would be, okay?
Yes, yes.
And then I'm going to talk about reality.
Okay.
So the ideal is reflected in a variety of data. So first of all, when you look at hunter-gatherer populations from around the world, their LDL is typically between 35 and 55. They are typically remarkably resistant to the development of atherosclerotic disease, and they live perfectly happy, healthy lives. There's nothing wrong with an LDL of 35 to 50 lifelong. When you look back at the adult treatment panel number 3, they published a white paper in 2004. And in that white paper, there was a log linear display of the relationship between LDL and the hazard ratio for an ischemic heart disease related event. The hazard ratio of 1.0, meaning no excess risk for a cardiovascular event, occurred at an LDL of 38. And so ultimately, we were never meant to have the LDLs that we currently harbor. our development as humans has outstripped the capacity of evolution to accommodate these enormous changes in lifestyle and diet. And so if I had my druthers and someone looked me in the eye and said, what should my LDL be if I want to make sure I don't get atherosclerotic disease? I would tell them probably get your LDL to 40 and make sure your blood pressure is controlled, that you don't allow yourself to become diabetic, you exercise and don't smoke. Now, realistically, can I get everyone to less than 40? The answer, as you know, is of course no. I can't get everyone to 40. But if I do prescribe a statin and I want to minimize this patient's risk, then even with intermediate risk, I will do what I can to lower their LDL to 70 or less. I treat them as a high-risk patient. If they're going to take a statin, you may as well get as much benefit as you can and make it meaningful.
Mm-hmm. Got it.
Yeah.
Thank you.
Excellent.
Thank you.
Yeah. So the last presentation you did about the Pioneer trial, Pioneer 3, I think. So what do you think, is the, take home for all of us and in terms of real usage of this information on a day-to-day basis?
Yeah, that's tough because it's only 1 year of the trial and it's going 5. But at least in the short term, it looks like the secondary endpoint was somewhat lower, though it didn't hit statistical significance. There's a trend for benefit with the newer stent. Obviously, we want the 5-year data. I am very intrigued as a biochemist as to the impact of focusing on re-endothelialization, limiting smooth muscle cell infiltration, clonal expansion of the smooth muscle cells, and how specifically that can impact risk for in-stent thrombosis. But right now, I'd say it's too early to tell, and we just need to see where the trial goes. But I think conceptually, it makes tremendous sense. Everyone's on mute. Dr. Chandra, Dr. Mehta, you're both on mute.
Okay. Yeah. So basically, I think, you have covered such a great deal from the latest and the best from AHA. And I think, this was a very nice, evening for all of us. And it's already getting to 9:37 now. So if there are no more questions or if there's anything which Dr. Mehta would like to highlight at this stage.
I want to say one thing. Peter, this is not a flattery, but I was glued to my chair as if I'm watching a Hollywood thriller throughout.
Thank you.
It was wonderful. Wonderful. And your insights and the mechanistic pathways and the knowledge of biochemical, all this information.
Very complex.
Very, very complex, but certainly made easy for us.
Thank you.
Yes.
Thank you.
So
Thank you very much.
On behalf of Lupin Limited, I would like to thank our international faculties, Dr. John McMurray and Dr. Peter Toth. As doctors were saying that you have made it so simplified for Indian audience. So we are extremely thankful, for sharing the best evidences and sharing it in such a simplified way. I would also like to thank our chairpersons, Dr. A.B. Mehta and Dr. Praveen Chandra, for sharing their, analysis and insights on these new emerging evidences which has come through. As we speak now, we have almost 1,100 audience glued to the session. So we are thankful to each one of them for accepting our invite and being part of the session. I'm sure it would have been a very enriching session with all the stalwarts, from globally as well as India being part of this session. Thanks a lot to each one of them. And thank you, doctors, for your presence. Good night.
Thank you. Good night.
Thank you.
Bye.
Yeah, Mr. Jinai. So
Yeah, you
they
can.
all logged out. Yeah.
Thank
They all
you.
logged out. Yeah.
Thank
So
you.
thank you for this opportunity.
Thanks, Raghu. Thanks, Raghu. Nice seamless session.
Yeah. Thank you.